Welcome to The Explainer. Today we're doing something a little different. You're going to step into the shoes of a clinician, right into the thick of it. We've got two medical mysteries where a fast, accurate diagnosis is literally the only thing standing between a patient and a really terrible outcome.
So think about it. This is detective work, but the stakes couldn't possibly be higher. The patient's body? That's the scene of the crime. The symptoms are your clues, and you've got to unmask the culprit before it's too late. So let's get our investigation started.
Okay, case number one. This one's all about a patient whose symptoms seem to point in a really obvious direction. But the real cause, the thing driving everything, is something else entirely. It's a hidden factor that changes the whole game. So let's meet our patient. He's a 67-year-old man, and right off the bat, we know something important about his history. He has type 2 diabetes, and it's not well managed. That's the first piece of the puzzle we're putting on the board. Now, he comes in because for the last 3 weeks, things have been going downhill. He's finding it harder and harder to swallow, he's lost a lot of weight, and it just plain hurts. You take a look in his mouth and yep, there it is. Extensive white patches all over his tongue and the back of his throat. For any clinician, seeing all of this together is a huge red flag. This is our first major clue that we're dealing with a pretty nasty infection. All right, time to gather more evidence. The team takes an oral swab, and just as suspected, it comes back positive for yeast. They use a tiny camera to look down his throat, a procedure called an OGD, and see the infection isn't just in his mouth. Those white plaques go all the way down his esophagus. The lab confirms the culprit is a fungus called Candida albicans. But wait, the investigation can't stop there. You have to ask the most important question. Why? Why would a person have an infection this severe? And the answer reveals that hidden factor we were talking about. An HIV test comes back positive, and his viral load is incredibly high. And this number right here, this is what makes it all make sense. We're looking at his CD4 count. These are the general cells of his immune system. A healthy person, they'll have a count over 500. His is just 112. This single number tells us his immune system is severely, dangerously compromised. And that is what allowed the Candida infection to just take over. So you see, this was never just a throat infection. It was a major complication of advanced, untreated HIV. So now we have the complete picture. We know the what, it's esophageal candidiasis, and we know the why, it's because of advanced HIV. So with all that information, what's the single best first move? What's the right treatment to start with? And here's the key. The infection is deep down in his esophagus. So a topical treatment, something that just coats the mouth, it's not going to touch it. We need a systemic drug, something that gets into his bloodstream and attacks the fungus from the inside out. And that is why the correct answer is B, oral fluconazole. Let's just quickly run through why the others are wrong. Nystatin, it's topical, so it's out. Caspofungin, way too strong. That's a heavy hitter you save for really resistant cases. And metronidazole and vancomycin, well, those are antibiotics. They're designed to kill bacteria, not fungi. Using them here would be completely useless. It's all about picking the right tool for the specific job. Okay, so case one was a slow burn, a mystery that unfolded over weeks as we dug for that hidden factor. Case two is the complete opposite. The timeline here isn't weeks, it's hours. This is an absolute race against the clock. Our patient is a 23-year-old university student, and we get one absolutely critical piece of information right up front. He's not vaccinated for meningococcal disease. For a clinician, hearing that in this context sets off all the alarm bells. And look at this timeline. In just 24 hours, he's developed this terrifying group of symptoms: a raging fever, a headache so bad he can't stand light, and he's getting confused. But then, during the physical exam, you find the classic telltale sign, neck stiffness. This whole picture just screams one thing: there is dangerous inflammation happening around his brain. What's so incredible here is how every single number on this chart tells the exact same urgent story. They do a lumbar puncture, a spinal tap, to get a sample of the fluid around his brain. And look, the pressure is way too high. The white blood cells, which should be almost zero, are through the roof. The protein is sky high, and the glucose is dangerously low, and that's a huge clue that bacteria are in there, literally eating it for fuel. And then you have the smoking gun. The Gram stain, a special dye, makes the bacteria visible under a microscope, and there they are, the classic shape of the bacteria that causes meningococcal meningitis. So there's no doubt anymore. This is acute bacterial meningitis, and it is a true medical emergency. Every single minute matters. what is the most critical action you can take right this second? In a situation like this, you have to hit the problem on two fronts, and you have to do it immediately. First, you need a powerful IV antibiotic to start killing the bacteria. And second, you need a steroid to fight the dangerous inflammation and swelling in the brain. That's why the only right answer is A, the combination of ceftriaxone and dexamethasone. Just so we're all crystal clear, this condition is an infection of the meninges. Those are the protective layers that surround the brain and spinal cord. When bacteria get into that space, the body's own inflammatory response can be just as deadly as the bacteria themselves, causing swelling that can lead to permanent brain damage or even death. Choosing any of these other options would be a tragic mistake. Vancomycin by itself doesn't cover the right bacteria. Oral azithromycin is like bringing a squirt gun to a forest fire. Nowhere near strong enough. Acyclovir is an antiviral, totally useless here. And while a paramedic might give penicillin in the field to get things started, it's not the definitive choice once you're in the hospital. That immediate correct combination therapy is everything. So we've just worked our way through two very different, very intense cases. What do they teach us? What's the fundamental process that a clinician uses to decode a diagnosis like this? Well, it really boils down to this clear four-step journey. You always start with the patient's story. Then you gather the clues. That's the hard data from exams and labs. Once you have the evidence, you identify the culprit. You name the diagnosis. And only then, once you know what you're fighting, do you choose the right tool for the job, the most precise and effective treatment. Both of the cases we saw today, as different as they were, followed this exact same logical path. Voltaire famously said that the art of medicine consists of amusing the patient while nature cures the disease. And hey, for a common cold, maybe he's got a point. But our two cases today show just how wrong that idea can be. For the man with advanced HIV or the student with bacterial meningitis, nature wasn't going to be the cure. Nature was the threat. Only swift, precise, science-driven medicine could save them. Which kind of brings us to one last thought. We've seen how absolutely critical knowledge is, but what separates a good doctor from a truly great one? What allows a clinician to look past a simple throat infection and ask the question that leads to the HIV diagnosis, or to see that cluster of symptoms and immediately know that time is running out? Is it just having more facts memorized? Or is there something else, in intuition, maybe a kind of pattern recognition that goes beyond the textbooks? That, I think, is the art behind the science.